Welcome back, ladies and gentlemen, to the Your Go-To Doc YouTube channel. I'm Dr. Robert Feldman, board-certified neurosurgeon, and today we're going to be talking about cervical degenerative disc disease, otherwise known as arthritis in your neck. This can give you neck pain, headaches, and maybe even pain, numbness, and tingling shooting down your arms. So let's get right to the video. Cervical degenerative disc disease, why it happens, why it hurts, and what you can do about it. Okay, so it's relatively hard to make these videos short, but I'm going to really try hard this time and try and keep this under a half hour. That's going to be tough to do, but let's get to the basic main points of cervical degenerative disc disease. So the spine in the neck looks like this. This is the front view. This is the back view. These are the little bumps going down the back of our neck. And in between the bones of the neck, you've got shock absorbers or discs. Don't think of the disc as this flat thing that kind of slides in and out. Think of it like a pocket of jelly. And that shock absorber, as we age, degenerates or wears out. The ligament that wraps around the disc starts to get brittle with little cracks and fissures in it. The disc material inside, which is a collagen-based material, eventually starts to deteriorate and change. And we'll look at some pictures, but this kind of spongy, nice shock absorber over time becomes flattened, the bones get closer together. That shock absorber not doing a great job can stimulate pain fibers inside the disc, which is going to give you that kind of deep inside neck pain. Because this shock absorber is not doing a great job, these little guys here, which are called facet joints, you have one at each level on each side, these start to rub around too much. They're supposed to move a little bit anyway, but if this shock absorber is not doing a great job, these facet joints will rub around too much. The little nerves inside these joints will send a message up to your brain, and they're going to say, hey brain, we're upset down here, we're rubbing around too much because the shock absorber is not doing a good job. Do something about it. The brain's going to say, well, look, all I can do to help you guys out down there is keep all this still. And the way I'm going to keep all this still is I'm going to tighten up all the muscles back here. And that's why people with degenerative disc disease get not only inflammatory pain from the joints and the disc, but muscle spasm pain back here. And keep in mind, no matter where the shock absorber is not working, the same muscles typically tighten up. Paraspinal muscles, trapezius muscle, and that's why a lot of people with degenerative disc disease in their neck, causing neck pain, have pain low down here in between the shoulder blades because that's where the trapezius muscle attaches. So inflammatory pain from the joints rubbing around, muscle spasm pain from the muscles tightening up, trying to keep everything still. Keep in mind that this bad disc wearing out can lead to pinched nerve problems or spinal cord problems. If a piece of disc escapes out, it can pinch one of the nerves coming out of these holes. If a piece of disc comes out inside the deep middle part here, it can push on the spinal cord. And if bone spurs grow and push on the spinal cord or bother the nerves in these holes, you can get spinal cord symptoms or nerve root symptoms going down the arms. That is a whole different topic with a whole different solution to that problem, so we're going to talk about those in different videos. What we're talking about today is really mechanical neck pain from worn-out shock absorbers causing muscle spasm and inflammation. So let's take a look at some pictures. We're going to do some diagrams with drawings of the cervical spine. We'll look at some MRIs and X-rays, and this will give you an idea of what the actual pathology looks like when your discs start to deteriorate in your cervical spine. After that, we're going to talk about what your options are to fix that. So what you're looking at here is a cervical spine X-ray, and this is a side view of the cervical spine. So you're looking from left to right or right to left as opposed to front to back. So on this picture on the left, you can see the jaw bone right here, some teeth. On the picture on the right, you can see the back of the skull here. This triangular shaped bone here is C2. This would be C3, C4, C5, C6, and this would be C7. And what you can see in this picture on the left is all the spaces in between the bones, which are the discs or shock absorbers, look relatively plump and healthy. The edges of the bones don't look kind of ratty or irregular. They look kind of sharp edged. These are relatively healthy disc spaces. If we compare that to the right-sided picture, you again see relatively healthy discs everywhere except in between these two bones. And these bones are this is 2, 3, 4. So this is the 5 bone here, this is the 6 bone here, and you can see the arrows pointing here. These two bones are much closer together than all the other bones in the neck, and this is a sign of a single level degenerative disc between the C5 and C6 bones, so this would be called the C5-6 disc. Again, collapsed disc space, maybe a little bit of bone spur growing back here, but this is an example of single level degenerative disc disease in the cervical spine on an X-ray. Here is a diagram instead of an X-ray showing pretty much the same thing, except here you can see the nerves coming out of the foramen or holes in the spine. So on the left, healthy discs. On the right, arthritic or degenerated discs. Collapse, space, bone spurs growing in the front. It's a little hard to tell in this picture, but the holes for the nerves are smaller because of bone spurs growing off of these facet joints, bone spurs growing off these vertebral bones. All of those can make the nerve pinched, causing arm symptoms, or deeper into the middle of the spine here, it may cause pinching of the spinal cord, which can lead to other symptoms, which we'll talk about in a different video. So these are diagram images of healthy discs on the left versus degenerated discs on the right. So now let's take a real quick look at some MRIs of the cervical spine, and these are lateral views similar to the X-rays we looked at. And here we see on the left a normal cervical spine MRI. This is a T2 weighted image in which anything with a lot of water in it will be bright white. So here you can see the spinal cord coming down the center. The squares are the bones, and again, these stripes in between the bones are the discs or shock absorbers. And here you can see they all look relatively plump, nice and sharp-edged, nice bright signal inside of them. And this is what a healthy cervical spine image looks like on an MRI with healthy discs. If we then move over to this picture on the right, and again, it's going to be hard to find a cervical MRI with a single degenerated disc. Usually they all start to get degenerated little by little. But here is a relatively good example of nice, bright, plump discs. And then this guy here in between is relatively dark compared to all the other ones. And that's an example of a disc that's starting to dehydrate and degenerate. If we move on to the right again, we can see this disc has some dark signal changes above and below the disc into the bones. That's called reactive end plate changes or modic end plate changes. And this is a sign of irritation in these bones because this disc is not functioning well and things are rubbing around too much. And then if we keep going to the right, we see again nice plump discs in these first 3 discs. And then in the 6th disc down here, nice and plump. But here's 2 discs that not only are collapsed, not only have these disc bulges coming out, but you can see some reactive end plate change or modic end plate changes in the bones above and below. And this is an example of 2 levels of degenerated discs on an MRI. So we talked about what cervical degenerative disc disease is, which is basically wearing out of the shock absorber in your neck. We showed you some pictures of what that looks like on MRIs, X-rays, and diagrams. So you have neck pain, you have muscle spasm, sometimes you'll get headaches because the nerves that go up the back of the head here get irritated by these muscles being in spasm all the time, and that can give you what are called occipital headaches. And you've decided that you need to do something about it. Well, typically you're going to go see your primary care doctor. They're going to try some over-the-counter medications, maybe some prescription medications, maybe some physical therapy, maybe some pain management with injections. Let's say all of those things really don't calm the symptoms down to the point where your quality of life is not interfered with enough, and you want to fix it. So your primary care doctor, your pain management doctor, your chiropractor will probably send you to a neurosurgeon for consideration of fixing your bad discs in your neck. What are they going to tell you? Well, they're going to basically say, we got some pictures of your neck, you've got a couple of bad shock absorbers. The solution to fixing that is what's called a cervical fusion, which basically means taking out the bad disc, replacing it with some kind of spacer, immobilizing the bones above and below that disc so they can't move anymore, and then over time getting those two bones to fuse together. Well, if those two bones fuse together, they don't rub around anymore, the bad disc doesn't matter, and all the inflammation in the joints and all the signals going up to your brain saying tighten up your muscles go away because those bones stop rubbing around anymore. I can tell you I've probably done a couple of thousand of those surgeries. They are wonderful surgeries. They don't hurt very much. They're usually very effective in accomplishing the goal of not letting those bones move around anymore. The success rate of the bones fusing together is very high. But having said that, I will tell you, I'm not a big fan of offering cervical spinal fusion surgeries for patients with just neck pain. Why is that? Well, before we go into why I don't like to offer cervical spine fusions for patients with just neck pain, let's go over what's involved in the surgery that you would go through if you did go through with it. So you'd see your doctor your neurosurgeon in their office, you'd pick a day, they'd get some blood tests, an EKG of your heart, probably a chest x-ray, make sure you're healthy. You'd show up at the hospital, meet the anesthesiologist, they bring you into the operating room, they put you to sleep, put you on a special table in the operating room. They may attach some kind of gadget to your head that they can stretch your head up to open up the space for the disc to do the surgery. They will wash your neck. It can be done from the right or the left side. Some special, killing all the bacteria wash. They'll usually make a little incision horizontally in your neck, try to put it in a crease in the neck so that when it heals you can't notice it very much. And then they'll kind of separate the muscle groups and go down to the spot where the front of your spine is, and they will basically use a microscope to cut out the ligament right in front of the disc that they want to fix. They'll scrape out all the disc material, scrape out all the cartilage, and they'll basically make that space an empty space. Bone, empty space, bone. And then what they'll do is they'll take a little spacer, and that spacer looks like something like this. It can be made of different materials. It can be made of cadaver bone from a cadaver. It can be made from a material called PEEK, which is polyethyl ketone. It looks and feels like plastic, but it actually has a little give to it, the same give that bone has. They can use titanium, various materials that they create a spacer like this. And these spacers come in different sizes, and they'll usually pick one that will prop your bones apart to be like they are or were when they were healthy. You'll notice that this spacer has a little hole in it, and that little hole will be packed with something that makes bones grow together fast. Either a synthetic or biomaterial that's made in a laboratory, or a material that's harvested from living cells, or a piece of bone from a cadaver, as I said. And in that case, they sometimes don't have to put anything in the center. They'll take that little spacer, they'll tap that in where the disc used to be. Tap, tap, tap. And instead of bone, disc, bone, you will now have bone, spacer, bone. And the ultimate goal is to get those two bones to grow together. Well, a good way to get bones to grow together fast is to keep them still. That's why if you break your arm, you break your leg, they put it in a cast. Well, the way that we keep the bones still in the neck is with a titanium plate. And that plate looks something like this. Now, this is a 2-level plate, meaning it spans 2 disc levels, but a 1-level plate would kind of just look like that. And that plate with 4 little screws is put on after the spacer is put in where the disc used to be. And that plate basically keeps these 2 bones still while the bones grow together. It typically takes about a year for the bones to solidly grow together, And at that point, you technically don't need the plate and the screws anymore, but you don't go back in and take them out. They just kind of sit there and don't do anything. And that whole surgery to scrape out the old disc, put in the bone plug, put in the plate and the screws, takes about an hour and a half, maybe 2 hours. And that is called a cervical fusion. And that typically is used to keep those bones still from not rubbing around anymore. Now, why would I not want to do that for someone with just neck pain? Well, the reason is that if you fuse 2 bones together like this, or 3 bones together like this, then they don't move anymore. And that means that the disc above and the disc below this surgery now has to pick up the slack. And technically, they're not designed to do that. This stiff section in between them puts extra stress on them, which means whatever arthritic changes were going to happen here and here are going to be accelerated. And the statistical risk that you will need another surgery here or here, above or below your fusion, is about 20%. The other problem that I don't like because of this is that, as I said, these discs are probably all degenerated. It's not just the 2 that you fixed. So the chances are the patient's still going to have neck pain after the surgery. It's possible they may have a year, maybe 2, where the neck pain's improved because it was mostly coming from this disc or this disc, which you now fused. But in the end, these guys are going to pick up the slack and your neck pain's going to come back and you're going to end up returning for another surgery and you're going to be marching up and down your spine until your entire cervical spine is fused. So I'm not a big fan of offering cervical spine fusion surgery for patients with just neck pain and not, for example, arm pain or spinal cord pinching. So when will I offer surgery like this for patients with just neck pain? Well, typically they have to meet 2 criteria. One would be that there's 1 or at the most 2 discs on imaging, usually an MRI, that are clearly the most degenerated or causing the most trouble. And this could be in the setting of a single disc that shows bone spur growth or collapse on x-rays, or a single disc on an MRI that shows something called reactive end plate change, which is basically a bright signal in the bones above and below the disc. And we'll look at a picture of that in a second. So the other reason is if the patient's symptoms are so incapacitating that their quality of life is just miserable. And they failed all other options. So if they have 1 or at the most 2 discs that look really bad compared to all the other discs on an MRI and an x-ray, and they are absolutely miserable with symptoms of neck pain and headache, and they've tried everything else. In those cases, I will offer them surgery. I will fix the 1 or 2 discs that look the worst in the neck and fuse them together so they don't move anymore. But I will warn the patient that this will probably give them temporary relief of their symptoms, and that temporary could be a year, it could be 2 years, if you're lucky, 5 years. But I warn them to be prepared down the road that their neck pain may creep back into their lives, and the disc above or below where I fused may need the same surgery that I just did. So as long as they understand that, as long as they're willing to undertake the risks of the surgery, which I'll also talk about in a second, I will offer cervical spine fusions to patients with just neck pain and headache. So real quick, let's talk about what to expect after the surgery, and then after that we'll go over the risks of the surgery. So as I said, the surgery takes about an hour and a half maybe. You'd wake up in the recovery room, your throat's going to be a little sore, it's going to hurt a little bit to swallow, but overall I will tell you this is not a very painful surgery. For my patients, I'll usually put them in a soft collar overnight. I try to keep them in the hospital overnight if I can, if their insurance lets me, etc. But nowadays patients are often going home after this surgery. But I'll typically keep patients in the hospital, and that first night I'll just tell them to take it easy. They're allowed out of bed to go to the bathroom, but that's about it. During the evening and night of after the surgery, I'll have the nurses come in and check their throat for swelling, making sure there's no bleeding in there, making sure they can breathe clearly through their windpipe, as well as making sure that they don't have any stridor, which is a sound that you make when you have an obstruction of your airway here. So as you can tell, the big risk after this surgery, and even though it's an extremely low risk, is bleeding in the area of the surgery, causing pressure on the airway. So that first night, again, take it easy. The nurses check on them. They usually don't need very strong pain medicine. And then the next day, I take off the soft collar. Therapy walks them around the hallways. I usually come in around lunchtime. I look at their neck. I ask them how they're feeling. And typically what they'll say is their throat's a little sore. It hurts a little bit to swallow, but they can tell right away the neck pain feels better. Usually the patients notice right away. If everything looks good, I'll let them go home. 2 or 3 days stuck in the house. That doesn't mean lie in bed all day, but just stay home. They're allowed out of bed to go to the bathroom, up and down the steps once or twice a day if they need to, watch TV, read a book, take a nap, stare out the window, watch the grass grow. About a week after the surgery, they can drive, short trips only, the bank, the post office, the grocery store, that kind of thing. But for 2 weeks, I basically want them to be a slug, and that means no pushing, no pulling, no reaching, no lifting more than 5 pounds, no housework, yard work, walking the dog, taking the trash out, exercise, home improvement projects, hang gliding, skydiving. Lay low for 2 weeks, even if they feel fantastic. If they refuse to do that, if they do not follow my instructions, I basically warn them that they're not going to really ruin anything I did, but it'll just take them longer to feel better. I do mention to patients that sometimes when you have a collapsed disc and you stretch that space apart to put the spacer in and keep it apart like it's supposed to be, that act of stretching the disc apart can actually irritate these facet bones here and stretch them apart and make the little nerves in there upset temporarily until they get used to that new position. So I do warn patients they can get some in between the shoulder blade muscle spasm for the first couple weeks after the surgery, but if they follow my instructions for what to do after the surgery, that time spent with some muscle spasm in between the shoulder blades will be minimal. They'll be back in my office at 2 weeks for a checkup. I'll look at their incision. I'll ask them how they're feeling. We'll get an x-ray, make sure the plate and the screws look good on the x-ray. And if everything looks good at 2 weeks, I'll let them slowly add their activities back little by little over the next 4 weeks, which basically means by 6 weeks after the surgery, they're pretty much back to their routine. If they have a desk job, I'll let them go back at 2 weeks. If they have a manual labor job, typically 4 weeks or 6 weeks. I'll then bring them back about 2 months after the surgery with another x-ray. Make sure, again, the incision looks good. Make sure any of the discomforts from surgery have gone away. Feeling like they've got a shelf in there, catching food or trouble swallowing. Rare, but if that does happen, it usually is gone by the 2-month mark. The shoulder blade muscle spasms should be gone by 2 months. If the x-ray looks good at 2 months and the patient sounds good, from my perspective, they've graduated, they're off the hook, they don't have to come back. Keep in mind that kind of order of events after the surgery can vary by surgeon. Other surgeons may have different specific preferences. Some surgeons will keep patients in a hard collar for a couple of months. I don't think that's necessary since we started using the plates and the screws. That locks those two bones down pretty tight. I don't think you need a hard collar if you have a plate and screws. So that's typically the post-op time course after that surgery. So now let's talk a little bit about the risks. So there are 3 risks for any surgery. It doesn't matter what kind of surgery it is. Ingrown toenail surgery, brain surgery, same 3 risks: infection, bleeding, problems with anesthesia. All very low, but those risks are in the book, so we have to tell you about it. Before the surgery, we typically get the blood test, the EKG, the chest x-ray to make sure you're healthy, and that helps minimize the risks of anesthesia. Those include things like blood clots in the legs, heart attacks, pneumonias, those kinds of things. Risk of infection is pretty low. That's why we do the surgery in a sterile operating room. We wear gloves and masks. We paint everything with iodine to kill all the bacteria. Even though we do all those things, there is still a risk of infection. Typically, that's less than 2%. And we also, at least I give my patients antibiotics before and after the surgery. And then the risk of bleeding is very low, but if it does occur, it can be serious. And that's why it's very important after the surgery to make sure there's no active bleeding, and when you irrigate out the incision, the return fluid that's coming out is clear. And that's also why after the surgery I have the nurses every hour for the first 7 or 8 hours check on the neck, check on the voice, check on the breathing. A couple of risks that are special to this surgery because of where it is. Spine surgery in the neck. So you are removing that disc from in between the bones in the cervical spine. The very back end of the disc, the next thing after that pretty much is the spinal cord. So when you're scraping out that disc material and the cartilage, you have to basically be very careful that you don't injure the spinal cord. And that's just practicing good surgical technique and being careful. The other thing is, excuse me, during the surgery, all the motions that you do, you want to make them either left to right or towards you. You don't really want to do any motion that is, downwards, because the next thing after the disc, as I said, is the spinal cord. So injury to the spinal cord is one of those risks. That could be something minimal, like a little numbness in the arm, or it could be something dramatic like paraplegia or quadriplegia. But that is a risk, extremely low. Another risk is something called spinal fluid leak. The covering of the spinal cord and the nerves not only keeps in the spinal cord and the nerves, it keeps in spinal fluid. If you get a tear in that covering, that fluid can leak out and give you headaches. There are ways to fix that. You can patch it, you can glue it. Very, very low chance for this happening in cervical spine surgery. It's more likely in lumbar spine surgery, still low, but it's in the book, so we have to tell you about it. And then another risk, which is also very rare but can be very serious, is injury to the esophagus. When you divide the muscle bundles and structures in the neck to get down to the spinal cord and put in the retractor so that all you're seeing is the bones of the spinal canal or the bones of the cervical spine, the esophagus is one of those structures that you have to kind of go to the side of and push out of the way or pull out of the way and keep behind the retractor. When you're using the instruments to do the cervical spine surgery, which can include things like drills, biting instruments, scraping instruments, if the esophagus is kind of pooching out from underneath that retractor, you can injure it. That can be very serious because the stuff inside of the esophagus is not sterile. And if you have a hole in that and you eat food after the surgery, those bacteria from inside your esophagus can get through that hole and into the space where the spinal bones are, and that can be very serious because that space communicates with the heart structures, but extremely, extremely low risk, but in the book, so I have to tell you about it. So I forgot to mention one last possible risk or complication that can occur with surgery for the cervical spine, and that is something called recurrent laryngeal nerve injury. There are two little nerves that run up both sides of the neck to the vocal cords, and when you go in to do the surgery that I'm going to mention, it can sometimes upset one of those nerves and cause a hoarse voice. Typically, if that happens, it gets better in a few weeks, but there is a very small chance that there could be some permanent hoarseness of your voice after this surgery. That is why, in particular, this may not be the right approach. For example, professional singers or opera singers, that kind of thing. And in that case, consideration could be done for doing the surgery from the back of the neck. There is a way to fuse the bones in the neck from the back, but we'll talk about that in a different video. So recurrent laryngeal nerve injury is one of those other risks. And those are the 5 or 6 risks to cervical spine surgery, particularly cervical spine fusion. So in summary, we've talked about cervical degenerative disc disease and the possibility of fixing that for symptoms of neck pain and headache. And the surgery to fix that is a cervical fusion where you fuse the bones together. Other videos that I'm going to do are going to talk about pinched nerves and pinched spinal cords and options for that. But for just mechanical neck pain and or headache from degenerative disc disease of the cervical spine, the cervical spinal fusion is the most common surgical option. Now there is another option which is called an artificial disc. That technology has come a long way, but just to give you an idea, this is kind of an example of one of the original artificial disc concepts. There's one bone, there's the other. This is the front of the cervical spine, and you can see this kind of ball and socket technology for an artificial disc. And the purpose of this is to anchor this structure to these bones above and below, but still allow movement of the cervical spine. So the main goal of artificial disc is preservation of movement of the two bones in the neck that you're trying to fix. I've done artificial disc surgery. I am not a big fan of that surgery for many reasons. One of them is the bones often go on to fuse anyway, even after you put in the artificial disc. And number two, particularly for patients with mechanical neck pain from bad discs in the neck, the reason they're having mechanical neck pain is too much movement. The disc isn't working well, the shock absorber is not working well, the bones are rubbing around too much. Well, in those cases, typically in those patients who have advanced arthritic changes in their neck, the back part of the spine is also arthritic. And to do an artificial disc surgery, you really need the back part of the spine, these facet joints back here, to be healthy. So if you put in an artificial disc in someone with advanced degeneration of the cervical spine trying to fix a shock absorber that's allowing the bones to move around too much, you're really not helping them because the bones are still moving around too much, the joints in the back are still very arthritic, and my experience is that surgery is not very helpful for this patient population. In my opinion, the real reason to consider an artificial disc is in a relatively young person with relatively healthy joints who, because of trauma or some activity, has a big herniated disc that escaped out of their disc space and is pushing on a nerve or their spinal cord. In that case, preservation of motion in that young person who has healthy structures back there, after you've unpinched the nerves in the spinal cord from whatever's pinching it, is probably or might be a good idea because it will minimize the chance of the disc above and below that artificial disc that you put in degenerating faster or more quickly and eventually giving them trouble from the disc above and below the disc that they had problems with. So an artificial disc, in my opinion, is really an option for young people with big herniated discs pinching nerves. In those cases, it may be worthwhile, and the drawbacks will not be outweighed by the benefits. So I attempted to make this video shorter than my other videos, but that also meant that I left out a lot of detail. But I hope that the level of detail was enough to just give you the information that you need to kind of make you feel comfortable about what cervical degenerative disc disease is, why it hurts, and what your options are, as well as what to expect before, during, and after the surgical option for that, and the risks. I'll add a little more detail in subsequent videos about cervical herniated discs and pinched nerves, or cervical stenosis, which means pinching, and impingement of the spinal cord. Similar surgery, but different goals. In that case, not only are you attempting to fuse the bones together and stop them from moving around, but you're attempting to unpinch things. So please tune in to those videos regarding those particular topics if that happens to be what interests you. So I hope this information makes you feel a little better about what's going on, as well as maybe prepares you for your appointment with your neurosurgeon or orthopedic spine surgeon. And please, if you think this helped, like and subscribe, share it with friends, and don't forget the most important thing about all of this is, that's it, stay healthy.